Hi guys. So, hello, my name is Michaela Kincaid and I'm a PA student that's going to be assisting with your care today, okay? Okay. So, today we have a 24-year-old male presenting to the ER with sudden onset chest pain and shortness of breath. So, taking a look at our patient's past medical history, he does have Marfan syndrome. Not currently taking any medications right now, though. And upon a quick review of symptoms, we ask him some questions like, where is this chest pain at? Turns out it's localized to the left side only. He is having that shortness of breath. He does feel like his heart's beating kind of fast. He's coughing every so often, but not very often. And yeah, he's in some distress right now. So, well, first thing I want to do, I've observed the patient's general appearance. It does look like they're in a little bit of respiratory distress, so I'm going to take a quick listen here and see if I can hear anything significant. Yeah, so the breath sounds on the left side are actually absent, so that's not great. And then let's take a look at what all of our vital signs are. So heart rate is 132, so he is tachycardic. Respiratory rate is 28, so that is pretty high. Blood pressure is okay, 122/76. Oxygen saturation is at 93% here on room air, so that's not great. Temperature is normal, no fever. It is worth noting that this patient is 6'5" and only 180 pounds, bringing the BMI to 21.3. So this is a very tall, slender male. On physical exam, so we took a listen and noticed those breath sounds on the left side were pretty much absent. And then the chest pain is unilateral. We also performed some tactile fremitus, say 99. Yeah, it's decreased on that left side. Chest expansion, take a deep breath for me. Thank you. So yeah, chest expansion is only unilateral. It's only expanding on the right side, not the left. And percussion to the left side is actually hyperresonant. So I suspect that this lung might be collapsed. So as far as diagnostics go, I definitely want to get an ABG on this patient, arterial blood gas, to see what's going on there. And voila, it turns out the patient is hypoxemic and also has acute respiratory alkalosis, so that's not great. And then I do also want to rule out an MI, so I'm going to do a cardiac troponin as well, which is normal, so that's good. And then chest x-ray is positive for a collapsed left lung. I've got a super well-defined pleural line, which is abnormal, lucency, absent lung markings, and actually a mediastinal shift to the right side because that left lung is collapsed. Oh, I'm sorry, baby. Okay, so my differential diagnosis, my very top one is a pneumothorax. My second is a myocardial infarction, just because any patient coming in with chest pain, no, don't run away. Any patient coming in with chest pain, we want to rule out a heart attack. And then a pulmonary embolism, those things can have a sudden respiratory onset as well, so we want to rule that out too. So like I said, my top diagnosis is a pneumothorax. What I'm going to do is give the patient some oxygen because theirs is so low, and then we're also either going to do a simple needle aspiration or we're going to insert a small bore chest tube, and that is going to actually drain the air that's trapped in that space and allow the lung to reinflate. So as far as my clinical pearls, I just want everybody to understand what a pneumothorax is, understanding that it's that air building up within the pleural space, not in the lungs, but between the lungs and the chest cavity. And so it's actually putting pressure on the lung, causing it to collapse, which is why our treatment makes sense. And then our risk factors as well, like I mentioned with our poor sad patient here, he does have Marfan syndrome. He's also a young, slender male, and he's tall. So all of these things should make you think this patient is more likely to have a pneumothorax because those are risk factors. Other risk factors are also cigarette smoking and connective tissue disorders like what our patient has, Marfan syndrome, as well as Ehlers-Danlos syndrome as well. So those are things to keep in mind, especially in your clinical vignettes and in real life. Thanks.